It's just after 3:30 and I'm about to head to the airport to catch a flight to Amsterdam to the ESSIC conference, and I thought you might like to come with me.
Absolutely huge and Christmassy.
So I've snuck into ESSIC early and it's completely empty because it's an international conference, so no one turns up early, and this is what the hall looks like at the moment without anybody in it. Some really interesting research from here that I've picked up that I will be putting on the blog after this at some point. Getting a cup of tea really is the most important thing. It's completely empty here, and I must point out that the Dutch are very good at tea, that we have a full selection, including cut your own herbs for your tea, which is my favourite bit. Okay, good morning. I'm very tired. We're on to day 2 of ESSIC's conference, which is not in Essex, it's in Amsterdam. I had a really, really interesting dinner with quite a few researchers and some clinicians. Just the best part of a conference is coming and seeing and meeting the people here, and seeing what they're up to and learning from them. We had so many chats that were, ranged from mesh to surgical procedures to managing BMI and issues in different countries and drug use, and we're in Amsterdam, so they have a lot of CBD oil use. So yeah, when I can get my thoughts together, I'll put that on here as well. I'm having a great time. It's a massive learning opportunity, but it's so far very biomedical, very surgical orientated. I'm hoping today's going to change that, but we shall see. Until then, I'm going to finish my porridge, brain food, not hungover food, brain food. And we'll see what today holds. Walking with Carolyn. So yes, we are in the toilet of the conference venue. It's the only place I can find to talk. Kind of halfway through day 2, we're on MDT day. So far we've had chats from an anaesthetist and a gastroenterologist, some other kind of different areas of the urology specific team. And I'm a little bit disappointed. It's really biomedical so far. I mean, it's very important that we look at all the different kind of treatments, especially from a medical point of view, and ostensibly this is a surgical medical conference, but it would be nice to hear some other voices and have a better understanding of pain theory and of the patient. There's been a lot of MDT mentions, but they tend to be, the MDT needs to help us with prescribing another drug. So I'd quite like to see what develops from that. We've got the sexologist, the physio, and some other people coming up soon. So I'm hopeful. If not, I'm going to be standing up and doing lots of talking. Bye bye Amsterdam. It's been great. My head is full. I'm very tired. I have lots of thoughts about the conference, and alongside Carolyn, we were both a little bit disappointed, but also it was very interesting to see where many of these urologists' heads were at, and I think, I'm going to get some thoughts together, and then maybe I'll have a little bit more of a cohesive understanding of what we've just observed. For now, I've got to get a plane. Hi. A few apologies that was a little bit blurry in places. That was me experimenting with blogging, and I'm not sure if it's in my future. Hi, I've just been to ESSIC, which is the European Society for the Study of Bladder Pain Syndrome, previously called Interstitial Cystitis, to their annual conference in Amsterdam. And I had a really good time. I really enjoyed the conference. Not necessarily for the content of it, but I did enjoy it. And one of the best things of going to conferences is meeting all of the researchers and all of the other people that are really, really interested in the area that you're interested in. And so going to these kind of conferences is a bit like finding my tribe, which I know a lot of you are, if your physio is listening to this, but it's just lovely going to a conference. And the best thing is having enough energy to go for dinner and have a chat with some of the world's best researchers that I've been quoting for years. So I had a great time. And what I wanted to do today was talk a little bit about the points that have come out of ESSIC and my thoughts around them. So they are personal thoughts, not that I represent anyone but myself, not necessarily what was said at the conference. I really did enjoy the conference, and I thought it was very well organised, and it was really nice that it brought everyone together for all of it. And one of the best things about it is that they gave a whole session to patient advocates, so to organisations and groups of patients. That's brilliant, and we should see that more at conferences, because they were really able to put forward what they're up to, and they're fantastic organisations that are doing lots of research. We had some amazing research come out of the Dutch patient liaison group, who are really they're using questionnaires to talk to their what are they called? People that go to their courses, conferences and things like that, their supporters, to really ask them questions about their bladder pain symptoms. And that's invaluable. So they're doing some fab research. We've also got lots and lots of networking opportunities, lots of supporting stuff. And I think they have such a valuable role to play. We need to have more of that. So if we can get more patient support groups involved in conferences, we should. And I know that happens at ESSIC, which is the Mothers with Anal Sphincter Injuries in Childbirth group. They are heavily supported by their patients and patrons. So more of that. Right, I have my list. So ESSIC, an overview of where we are, or where ESSIC is anyway, and this specific conference. And you've always got to remember that the conference is curated by someone with a particular viewpoint, and other people that get involved on the team that are developing a conference. And this particular conference was heavily biomedical, and that was quite disappointing. I've got to choose my words carefully, but I think we've come so far, and certainly having been exposed to the amazing work at World Congress on Abdominal Pelvic Pain, where we get huge amounts of research and evidence, and they feel mind-blowingly progressive. We're all talking about singing from the same hymn sheet at WCAP that I've been to in Washington and in London, where they're very progressive and very integrated care from consultants and physios and AHPs and aligned. Whereas this felt very much like a Hannah's lesion conference, where I found out loads of really useful information. The first day was very much surgical based, and it's always incredibly useful for physios and to go and listen to what surgeons have got to say and what they're learning, because we pick up specifics of their techniques, positioning, the things they do, the way they talk, the way they think, and I'm mostly interested in the way they think about patients. And we can get better at how we communicate with our consultants if we have an understanding of what they're trying to achieve. So I learned lots about how to use lasers, about how they ablate, but the discussion mostly was focused about what to do when you've got a lesion and where to find the lesion. The problem we have with that, with Hannah's lesions, and I know that many people have talked to me about this online, and kind of many patients and Bladder Health UK people, is that we have two pieces of key evidence. So when we have the situation of bladder pain syndrome, which is where you've got urgency, frequency, pelvic pain lasting more than 6 months, gets worse when you hold, releases when you empty briefly, and it feels like it's pain around the bladder or anywhere around the pelvis. We have two pieces of evidence. One, that we know that Hannah's ulcers occur in patients without any pain. So in a normal population, you will find some people with ulcers in their bladder, and they won't be in any pain, and they won't be having any of these other symptoms. So, and I can think of 4 papers off the top of my head that have found this. We find Hannah's lesions in asymptomatic populations. So what's being suggested at the conference is that the lesion is the cause of the main issue, and that's a very reductive biological reason. I am not suggesting for a minute that it doesn't hurt. I am sure that there are people with ulcers like we'd have in our mouth, in our bladder, in the mucosa, that are very painful. They also seem to have, sorry, I'm covered in cat hair. They also seem to have quite a really good response to laser treatment, and that patients would thank them for it and ask for more. Those are the kind of outcomes they discuss, and I think that those are important. We should be looking at what people are telling us. We shouldn't be looking at random objective measures that we decide are important. However, My question is, if you're treating a Hunner's lesion with using laser therapy or electrotherapy ablation, and dilating the bladder, and you've got a cystoscope in there, and you've taken the patient in and you've given them anaesthetic, you put steroids in possibly afterwards, because a lot of them do that. Some of them are using chondroitin as well, and other gag layer replacements at the same time. With healing, there's lots of different discussion around there. I think it's very, very, very untrue to say that the treatment response is due to the lasering, because that's only one thing that you've done. And if you do loads of things at once, you don't know what will get people better. You have to do all of them again and again and again. Problem is, we can't laser someone who's awake, because that would be horrible. So we're never going to know. And I think a great degree of the improvement will be from a treatment response, which means seeing a therapist, having them listen to you, having them do something to you, you having belief in that doing. We know that's powerful. It sounds like I'm suggesting that people are silly, but I'm not. I'm saying from a neurophysiology point of view, and we know these patients are limbically driven in their pain, actually having someone listen and having someone try to get them better is incredibly powerful. And we know that the response to that can be reduction in inflammation, reduction in pain, reduction in frequency, and we have that measured. So I think the old adage that if you've got a surgical hammer, you find you will always crack a nut surgically, is what's happening here, is that they're looking for ways. They've got one technique here, which seems to be good, and they're therefore attributing everything to the improvement with this technique. So I find that really frustrating, because there was very little discussion of the biopsychosocial model. So first of all, that little problem about we have Hunner's lesions in asymptomatic populations. Therefore, we can't trust it as a diagnostic criteria. We can't look in someone's bladder and say, you've got a lesion, that's what's causing your pain, because we find them in normals. It's exactly the same as slip discs. I had a slip disc when I was 21. It was very painful, or 20. But we know that 20% of the population at the age of 20 are walking around with slip discs. Was my pain due to my slip disc? Probably, but possibly not. That's what we're looking at. We can't be clear on our diagnosis here. The second thing is, we know in BPS that if patients have a painful or tender pelvic floor, their symptoms don't improve. Pelvic floor's got nothing to do with the bladder. It's got loads to do with the bladder, but it's got nothing to do with the bladder. In their reductionist model of the bladder lining being the cause of the symptoms. And what can that tell us? We know that if the pelvic floor is involved, we know we've got an autonomic neuropathy in the pelvic floor if it's been in a tension state for more than 6 weeks. That means the blood flow is changed, the nervous system is changed. We know that the neural organisation from a somatic and sensory point of view up here is altered in those states. So we end up with a centrally driven issue, and therefore treating the pelvic floor makes the bladder feel better, and we don't touch the bladder. That wasn't even touched on. So I think I have massive issues with, I don't have a problem with looking at surgical techniques. I think that's really important, because we want our surgeons to be skilled, and I want them to share what type of laser they're using and how they ablate and how often and when they review and that kind of stuff. But if a conference position is meant to be MDT, we'll come on to day two, but if the surgical element of it is very, very much dealing with surgical problems and not surgeons standing up and saying, this is why the biopsychosocial is important, I think until we've got that, we're going to be stuck in this very divided system, which doesn't serve patients. It doesn't serve the human. So day one was for the surgeons, and very interesting for me. I made loads and loads and loads of notes. We also had almost a backward step, it felt like, in our definition and clarity about what we're talking about. And you all know I really think that words are important. So there was a question about whether interstitial cystitis and bladder pain syndrome are very different conditions. And what they're suggesting is that the Hunner's lesion positive bladder issue is interstitial cystitis, and bladder pain syndrome is the complex pelvic pain state that's over there somewhere. And they've kind of said IC is with a Hunner's lesion because it's treatable. And that's, it completely, it speaks to the kind of surgical mind of what they know, because they don't know any other techniques, because that's not what they do. So listening to lots and lots of wonderful the key researchers and scientists in the field that happen to be urologists, kind of not knowing what else is available apart from a little bit of lip service to psychological stuff is frustrating. The whole issue with Hunner's lesions and IC definitions is a little bit of a correlation bias that I don't think we have the evidence for yet. It's suggested that in bladder pain syndrome we can provide more conservative measures, but there's very little faith in them. You know, I had dinner and I went for drinks with consultants. I tried to talk to as many different people from different countries, and there were loads of different countries. I think I met one British urologist. I tried to speak to as many people as I could, and there was very little faith in physio or nursing or anything else. They were kind of I think that the burden upon surgeons is so great to heal patients, and they've taken that burden upon themselves, it felt like. And they're stressed by this burden that they feel like nothing else can help, or they don't know how. So what I'd love to have is an AHP conference just for surgeons and to show them what we do. So we have no further clarity on whether IC and BPS are going to be separate definitions. I know that the BMJ last year did a quick update in which they have decided, from a British perspective, that IC and BPS are different conditions. I argue that we're not in a position where we have the evidence to support that, and I think reducing patients with bladder pain syndrome and Hunner's ulcers into patients that will have laser, and then the ones that don't have the lesions having everything else, or we don't know what to do with them, it serves nobody. We need to treat both of these groups as phenotypes of one condition, one complex, beautiful pain state that requires treatment from many different modalities, including surgical in some cases. So yeah, I was a bit frustrated. But from my point of view, I'm going to continue to call it bladder pain syndrome. And there was a review of the guidelines, and the guidelines are ostensibly similar, but there's no clarity on that. So pelvic pain of 6 weeks to 6 months, pain with deferment, relief with emptying, more urgency and frequency, whether or not they've got Hunner's, whether or not they've got embedded infections. Infections wasn't mentioned at all, really. There was no discussion of embedded infections or longer term management, apart from on a couple of people that mentioned if patients were on antibiotics beforehand and things, but there wasn't any specific discussion of that, which was again interesting. From my point of view, I will continue to call it bladder pain syndrome because I think reducing it to less than that is a disservice to our patients, and that is my thoughts at the moment. Right, here's some good news. After all of the doom and gloom, I had such good high hopes for this conference, having been to World Congress, where I was like, oh, this is amazing, all these people are doing cool stuff and they're researching and they're really driven. Anyway, so the good news is we had an update from the MAP Research Network. I'm playing MAP Research Network bingo. So I met at Washington. I started how many people can I meet, and I carried that on in London, and I've just carried it on again, met a couple more people, heroes, who have done amazing research, amazing kind of basic level research into BPS. There was nothing new. We had a lovely update from Quentin Clemens, who is a delightful man. He's really lovely, and he cares a lot, and I think a lot of the research, everyone in this area, everyone at the conference cares a lot about patients. There wasn't anything new. If you follow the MAP Research Network, they've got another 3 years of funding, and I know they're looking at what they can do after that and whether they carry on, because there's quite a lot of specialist researchers there. It was good to be able to kind of grill him. I had dinner and we had a little chat. They're looking at a lot of the pathoneuroimmunology at the moment, which are the sexy words for the last couple of years, and looking at how they're trying to understand. I think they are doing a little bit of manipulation of stuff, but they're mostly trying to understand it. The IMI Pain Care Trip group, really, really exciting, led by Katie, can't remember her second name, didn't write it down, sorry, in Oxford, who's massive, and I've met Katie a few times. She put on WCAP in London. She's part of the IASP pelvic pain, what do they call it, segment of the Orange. She put on a fantastic conference at WCAP. I really enjoyed it this year. They are working at some really, really interesting stuff, and you need to follow her and look at what she's doing and the IMI Trip group. ERN. So this is where good news becomes terrible news, and I'm recording this the day before the election. Who knows what's going to happen? So the ERN is the European Reference Network. Amazing! This is something we all need to know about. So the ERN basically is a collaboration of huge amounts of specialists in every area. And it says, right, if you've got a rare form of epilepsy and you live in Bulgaria, and I think Bulgaria is in the EU, if it's not, I'm sorry, and your medical team don't know what's going on, then you can apply to the ERN. They will send all of the details of that patient to 10 different specialists who will look at it and to come together via they've got everything sorted. So they've got their online programs where it can be safely stored. They've got the communication going. They've got the whole infrastructure for this network. It's amazing. But yeah, your details will be spread around, and then they will come together and discuss and work out what's the best move forward for you. And if that involves you coming to a different country for some treatment, they will fund it. Amazing. Bladder pain syndrome counts as one of the rare disorders. I wouldn't say it's that rare, but it counts. Great, let's keep it there. And there is a network of urologists and specialist pain surgeons that will come together and treat people, and it's amazing. So you can get people sent all over the place. Unfortunately, Mr. Chappell was who's a UK surgeon, was the consultant lead on this group this year. He was the chairman, and he's had to step down because of impending Brexit. And I'll just let that sit down there for a minute. So Britain doesn't really have a response in there, because they're all thinking that if we leave, we're not going to be part of it anyway. And I'm just so angry, because I know this is only European region, but we are the best humans that we can be when we come together to work for our patients. And the thought that they're chucking out, they're not chucking, they've had to step down. The British scientists and the British consultants have had to step down and move away from it because we know we're no longer allowed in the group because we want to take back control. Anyway, we can talk politics later. But anyway, they've had to step down. And as of possibly 2 or 3 days' time, depending on what happens or when and if we Brexit, Britain and the UK isn't going to be involved in this network. So we're not going to have our wonderful surgeons, and our consultants that fight for patients like Susie O'Neill or France or whatever aren't going to have access to her. But they did before, and it's really well funded. They were saying it's extremely well funded by the EU. So this amazing medical network, which is the best of people, when the best of humans, when they come together to get people, regardless of where they're from, just to do the best for patients. So from Bladder Health UK and anyone listening, if we don't Brexit, then this is something you guys need to really take into consideration. Because if someone's struggling, it may be that we try and get them to the ERN and to get them somewhere to have the treatment that they need. So happy but sad. There was some other stuff from India. India's getting really organised. They've had some really cool conferences. They've got a very active emerging area of research, conferences, innovation, loads of innovation in India, because they're so populous and the infrastructure isn't there. They're doing really cool innovative stuff like online sessions for... Oh, there's a cat. Hello. Coming to join me? They're doing loads of innovative stuff like online sessions, online groups, online treatments, screening, lots of different stuff. So we can all learn from the Indian model, which is good. My next observation was the MDT was mentioned often. And at one point, there was a lovely urological session from Dr. Rob Moldwin, who said it would be very easy if everyone had Hunners, we'd be bladder-centric. But then he said we need to look beyond the bladder, and in these patients we need to look beyond the bladder. Hi! And it's hard to do that when that's what you do. There was a lot of chat about the MDT. We had a psychologist and a physio speak. The physio unfortunately spoke in a very biomedical model about all the stuff we do. Not all the evidence of the talking that we do and why treating someone's limbic system helps. I was heartened that the MDT was mentioned so often, and there were a couple of people that said they couldn't work without their nurses, and they were their keystone upon which their clinic was built. Hello. That the clinics were built around the nurse, who would decide when and what they do with patients. Oh, come on, sit down. Okay, there we go. But it was really hard not to want to talk and trying to chat. I tried to chat to people all the time, but it was really hard not to be annoyed at. It kind of felt like lip service because we were represented, but not in equal measure, and there was a bit of a focus on the problems, not on the solutions to the problems. It was a little bit frustrating. It felt like we were lip service again. There was a focus on comorbid conditions, which was really interesting as part of the MDT, and I found that very interesting because we had gastroenterology, rheumatology, and immunology and autoimmune issues, as well as the anaesthetist represented. And that was lovely because I think that is really important, that we are hearing all the voices from the MDT and really getting a bit of getting some recognition. Sit down, animal. That patients may need screening for autoimmune conditions which co-present, because often if we can treat the rheumatoid arthritis or the Sjögren's syndrome or other things, then bladders will kind of jump into line and they'll get a bit better as well. And we want to find any way to move forward. Okay, on to the cool stuff. What's new in the world of bladder pain syndrome? Right. So the newest bit that really hurt my brain, I took notes, can't say I understand them, is about sympathetic dysregulation in bladder pain syndrome. So we know that we all know that we have a sympathetic dysregulation, so we have an increased sympathetic neural activity within our bladder and our pelvis and systemically within the body. And the area that's coming out at the moment that people are looking at is about mitochondrial oxidative stress as a cause of this sympathetic system upregulation. So the focus was about reducing the sympathetic nervous system overdrive driven by the mitochondria within the cells, because this chronic stress causes bladder wall permeability and other issues. And they are looking at ways of modulating drug input to improve mitochondrial function, improve its the rigidity of its walls. I think it becomes more permeable and there are issues. So that was clear. That was very clever. Oh, animal, where are you going now? Mast cell activity. We know that it is much more complex than it suggests. So all of our models of, oh, there are mast cells and what are they doing? It's so much more complex, so much more complex. And again, not something I begin to understand. I would love to at some point, but it's much more complex. There is a lot of basic science going on at the moment trying to understand the role of what mast cells do, how they interact with other cells, how they grow stuff, how they make things bigger, how they upregulate lots of different chemicals. And they were using models of different types of cancers and showing what mast cells do next to the cancer cells and how they proliferate and increase in size. And they also looking at using immune suppressors, because the mast cells obviously drive inflammation. So the postulation is if we use some immune suppression, we might be able to reduce the inflammation. People may feel better in their bladder and it might kind of stop that chronic happening. But it's, again, not as straightforward as we thought. So there are some issues around immune suppression, immunoregulation therapy that needs further work. Everyone's paying a lot more attention to making sure that we get this right and that it's not oh, this is good, let's try this. They're really trying to put some work into finding out, is mast cell activity something we want to target, or is it something that we can reduce as a secondary issue to other issues? Okay, Botox. Interestingly, to those of you that follow receptors in the bladder lining, because that's cool, Botox has an effect on the TRPV1 receptors as well as the smooth muscle, which is thought to be its action, which I thought was really cool. I didn't realise that. I thought it was just going to be have an effect on the smooth muscle lining, but no, on the receptors as well. But they don't really know why, and they're not really sure. They think it's like with the central nervous system, sympathetic nervous system driving things. It's a big drug. It has the potential to be quite a revolutionary thing for patients. And you would imagine that drug companies might put a lot of money into research for Botox, yet the studies that were presented had very small numbers. Why aren't we seeing trials with hundreds and hundreds of patients doing Botox? Yeah, in the way of the camera. Do you want to be on this film? Hi! I was really blown away by the fact that we didn't see massive sample sizes and we weren't seeing really strong data. We were seeing case series presented. And that doesn't kind of smack true, being that this is a massively industry supported area. It makes me very suspicious. Maybe I'm just being overly pessimistic, but it makes me a bit suspicious of what data we're seeing, whether we're just being presented with the data that is tells the story, the narrative that they want us to have. So the bladder is out on Botox. The jury is out on Botox. I know that it really helps some people. I now have more reason why it might, if it's on the TRPV1 receptors as well as a smooth muscle. But again, it would be one of those adjuncts to everything that we're doing. Microbiome. That's another big area. My summary for this was there's definitely stuff going on, but they're not sure what yet. There is a distinct dysbiosis of OAB and bladder pain syndrome separately, so you get separate, very, very separate microbiomes in each case. But we don't know what that means, and it's really poorly understood. We don't know if they're drivers, if they're, chicken or the egg situation. SNS, sacral nerve modulation, sacral neuromodulation. Again, this is something that I know a lot of patients have had. Not a lot. A lot of patients come to me having had lots of other treatment, and they've had SNS implanted and it worked for a year or two and then it stopped working and it's been inside for 5 years and it's switched off. That tends to be how I come across it. That's my experience of it. It can provide some help in the short term. The problem with what was presented is that it was very much about small case series. And again, this is an industry-sponsored area of research. You would expect there to be hundreds of trials. I know in Wales we did 13 last year with one surgeon before he was told to stop, and that's only one surgeon. So, nationally there's got to be a good couple of hundred that have been implanted. I know the other conferences we talk about it. So where was the rest of the data? It makes me a little bit suspicious. Why do we not have a meta-analysis? Maybe it's just early days, but I think it wasn't a very particularly convincing argument at the moment. I'm all for anything that will help a patient, but I want to have some good evidence behind it before I suggest it or talking to the consultant about it. They also talked about PTNS and it having a good response, and discussed implantable versions of PTNS, which made me laugh. So the same kind of implantable needles that they put in, the wires that they put into sacral nerve modulation when they put them in through the spine, they would be doing that in the leg, and they showed pictures of surgery with it implanting it into the leg. So patients can go home and they don't have to go and see a nurse to have their posterior tibial nerve stimulated once a week for 12 weeks. They can just have the box at home, stick it onto their leg, onto the port, do the work, and then take it off themselves. So realistically, quite a nice way of thinking about doing it that's much more patient friendly because it's at home, but it requires you to have a massive surgery to your leg. And that was with urgency. Now, we had a little chat with a couple of us, and from a physio perspective, we don't have problems treating urgency. Urgency is something that I do some PTNS. I do acupuncture PTNS with patients. I don't do electrical PTNS, but realistically, urgency is a highly sensory related issue. Physio point of view, we're very good in treating urgency. So I think this would only be in an extremist case that I would be thinking about sending them. Again, it's amazing the new things that they're coming up with. It made me quite annoyed that we have, at the last count I looked at, I don't know, Carrie Burr has done a new lecture for ICS recently-ish, but the last time I looked, there was something like 86 randomised controlled trials into pelvic floor treatment for urgency, overactivity, for stress incontinence. And this kind of probably very expensive implantable device was put forward as a way of kind of, solving problems. But if you haven't got any pelvic floor support, you might not be urgent anymore, but you might be leaky. Anyway, I have issues with it. I think don't want to intervene quickly. The patient advocates was another point. but I've already talked about those. I think that's a really important thing. It's really healthy to have them represented at conferences. What was disappointing was that half the conference, or less than half the conference, watched them. And it made me a little angry. And I know everyone was tired, I was exhausted, and it may not be as clinically relevant if you're there to build your skills, but if you're there to become a bit more of a specialist in the area, or continue being a specialist in the area, you need to listen to your patients. The physio workshop, which was in the last morning, was heavily embedded in the biomedical model. It started so well. If you see my tweets, there were pictures of brains, and it had the periaqueductal grey, and it had the anterior cingulate cortex, and there was the limbic system represented, and I was like, yeah, brains, woo! It's not all about the brain. It's stuff in the tissues, but we've also got to consider the brain. We've got to consider the brain from a software point of view, and we've got to consider the brain from a winding up, emotional, limbic, everything else. It's a human in front of you, the embodied pain experience, body and mind. It went downhill very quickly from that. So we had bish bash bosh. The first presentation from a consultant Gray, I think he's an an osteopath, looked at manipulations and pelvic floor trigger pointing as a treatment. I had I made a comment about trigger points not existing, and can we stop telling people that that's what they are, because we give them monkeys to carry and then they ask their surgeon to cut them out. Can we stop injecting them, because areas of tension occur in a muscle where the force changes direction and in response to pain states. And can we start looking at what the evidence from 3-4 years ago, which was probably carried out 5 to 7 years ago, shows us about an autonomic neuropathy in the pelvic floor, increased tension, so we need to work it, but we need to desensitize it. So our trigger pointing therapy works not because we are getting rid of the knot, but because we are continually in an area in a way that is non-noxious. And the research and the evidence, he presented it, and I know it inside out. And he presented one of the studies as, again, another positive thing for, well, actually, he didn't present the Chiarioni one. He looks at the Fitzgeralds more often, which are very, very positive for trigger pointing therapy. But the Fitzgerald was their methodology was very individualised to the patient, whereas Chiarioni did true trigger pointing, press as hard as tolerable in 3 areas on each side of the pelvic floor. And their response rate was 20%, 22%, I think it was, which is barely placebo level, and that came out worse than anything else. And it shows us that if you do true trigger pointing, you don't make change, don't make growth. The difference that manual work does to the pelvic floor in someone's pain is in desensitization, in working with the visceral overflow, in all of the centralized methods, the fact that you're a nice person when you touch them, all that kind of stuff. It's bugger all to do with pressing hard on a bit that's sore. So please stop pressing hard on bits that are sore. You just become more of a bear to that patient. Then we had a lovely presentation. What was Joelle's name? I can't remember it, I'm sorry. Who presented about electrotherapy. And I love it because she went, I've been asked to talk about electrotherapy. And I'm glad that it's a workshop because I can learn from you and you can learn from me. And it was really refreshing and lovely. And she presented electrotherapy and she said, okay, so what about the wavelength, and what about the form, what about the ramp, what about the waveform, what we're going to do with it, what about this, what about that, all the different parameters, and said, and what does the evidence show? Well, it kind of says endorphins or this, and it's very unclear. What do you do? And the few little things that we can discern from it. But she said basically she came out with an idea that TENS can be maybe very useful, and having reviewed the literature, she feels that she might, instead of using TENS as a end goal, kind of an end stage treatment, she would put it into treatment a bit more readily at the beginning, which is a great idea. So, and that's a very simple thing that we can all carry forward. Unfortunately, the chat about vaginismus was beautiful, and she really showed all of the different wonderful dilator use, and it was really lovely as kind of a progression of dilator. But there was no discussion of the biopsychosocial method in that, and what a model looks like. And I myself, from a vaginismus point of view, I never use dilators. I use dilators where there is a true tissue restriction, so radiotherapy, hymenal restrictions, other kind of, lichen sclerosis, that kind of stuff, where you need to be stretching. But vaginismus is a functional response to a function, and it's kind of like saying, right, I'm going to stab you with this stick and it's going to hurt. What you're going to do is you're going to go home and stab yourself with this stick lots, and you're going to practice not hurting when I stab you with this stick. Yeah, it's a bit ridiculous. Asking anyone that's got pain down there to just insert something and relax around it and get used to it. It's graded exposure in the worst way. I think it's, maybe I have some personal kind of issues with this, but I think it's really traumatic. So I use wands, I use fingers, I use other things, and we grade our exposure in ways that move, because that's what that area does. Move and feel good, not lie back and try and stretch and change your response. Because if we could all blooming change our response, then I can look into this and say, anyone that's anxious, change your response. Anyone that's depressed, change your response. And then the world would be a magically better place. Let's all not have insecurities. It doesn't work like that. So I think vaginismus is a highly, highly, highly psychological issue. Yes, there are tension issues, but what's it driven by? Why does a muscle switch on? Anyway, there is a supercomputer in there somewhere. Okay, lastly, because I want to end on some positive, Bert Messlink, my hero. Caroline van Dijken and I were at this conference, and we stood up and we gave him a round of applause, a standing ovation, because he stood and he talked about the... Here's another cat. Hi. Apologies for the cat intrusion number 2. Bert Messlink was fantastic. He talked about the neuromatrix. He talked about neural inflammation as a driver of pain. He talked about predictive processing as a model. He talked about toll-like receptors and the immune response from mediators there and how we can change that. He also talked about the limbic system and how emotional pain is processed in the same way as physical pain when we've been in pain for a long time, and that therefore we need to be looking at those two things. He also talked about inflammation and that interleukins, amazing, one of our inflammatory mediators, are involved in the immune response and also in cognition. Isn't that cool? That's well cool. So again, there's a crossover of the physical, the emotional, the mental, and we have to be discussing all of this in treatment. Now, Bert is a urologist and a sexologist from Holland. He's a urologist discussing pain matrix and predictive processing in bladder pain syndrome. It was such a breath of fresh air. He ended with a statement that I love, which is, life is cognition. I just wish everyone takes that away from the conference, that life is cognition and we need to be not brain-centric. I don't want to be completely neurocentric. We need to be addressing the tissues, but to spend a whole day talking about how we burn away issues with ulcers that we have no strong evidence is the cause of pain in everyone with bladder pain syndrome. If we've got when we know that actually there are many, many, many facets to this condition, I think ending with a positive note of life is a cognition. All life is a cognition. So, in summary, I'm a bit sad. It feels a bit like we've taken a step backwards. There is no clarity about definition of diagnosis. It feels like we're moving away, certainly in that body of people that are there at the moment, moving much more towards a biomedical model. There were physio voices and there were other bits and bobs there, but again, we were quite biomedical model. And I don't think that serves our populace very well. Will I go to ESSIC again? Yes, I will. It's the most important European conference for exactly what we want to learn. But I think from my point of view, I feel like we have a long way to go to really unite in what we're talking about, and we want the best of surgery, the best of physio, the best of nursing care, the best of psychology, the best of psychosexual treatments to come together. And I didn't feel like this conference achieved that. It was lovely. It was really nice to meet everyone and to hear more voices, but I don't think it was necessarily the most reflective of current research or current state of play in my bias. I think it was very reflective of the current state of urology and how international urology sees bladder pain syndrome. What I'd love is for all of them to come to World Congress on Abdominal and Pelvic Pain and have some discussions with the urologists and the consultants there, because I think there is a whole other side to this that is not being considered at all. So what I've taken away from this conference is a bit more confidence. I think the world hasn't dramatically changed. I think when I went to WCAP and then WCAP again, it felt like, whoa, so much has gone on, and this is amazing, we've moved forward so much. And at ESSIC conference, I felt like not quite that we're in the 1950s, but that we're 5 years ago. We're talking about Hunner's lesions again as the primary issue that we need to think about. We need to think about them, but I think we need to be thinking a lot more holistically. And we've made so much progress in many ways to thinking a lot more holistically, in the truest sense of the word, think about the human. I think I'm going to take away the confidence that the next time that I'm at a conference, I really am going to be challenging people, but it's finding ways to do that politely, with respect, with humility. And that's a debating skill that I need to learn. So yeah, let me know what you think, how you're getting on. If you have the ability to debate with consultants and with people that are a bit more powerful than you, let me know. We all need to learn better. I will be putting out a couple more videos about bits and bobs soon, so look forward to those. But if I don't see you before Christmas, happy Christmas. I hope you have a lovely Christmas period. Happy Hanukkah. Have a lovely new year, and I'll see you in 2020 when I am on the road to getting my online course. My online course will be up at the beginning-ish of 2020. I'm going on a holiday in January, so I'm hoping it's going to be up February, March. And that's before I head to Toronto. So if any of you are Canadian and you fancy coming and joining me, I'm doing my first big international coming over to do a course in Toronto with Nelly at Pelvic Health Solutions in March. I think March the 21st, something like that. So have a chat with Nelly. It would be lovely to see you there if you are Canadian. Okay, bye folks.